I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness.
What kind of outreach should be done to help reduce the stigma and improve mental and physical health in the African American community and in other minority communities?
The type of outreach that is needed is multifold. One is going to be the issue of recognizing the differences within cultures in America. You have to recognize it, but two, the caregivers have to become students of culture. Too often, we believe that being knowledge of our own culture is sufficient to take care of other cultures, especially when you look at the culture in America and white being the dominant culture. I know here in Houston, half of the city of Houston is born outside of the United States. Half the population in the city of Houston
Mm.
was born outside of the United States. So, being a Houstonian and treating of patients in this geographical area, I listen to music that I would not normally listen to. I'll watch movies that I normally would not watch, and I'll listen and watch things that I don't even find quite entertaining just to be able to understand my population around me. I watch the news just to hear what is going on within groups and within peoples, the local paper. I do a lot of speaking around the country. I tend to prefer to watch the local news where I'm at just to kind of understand what's going on with the culture of that particular group. So, one, we've got to make sure that we understand culture to reduce stigma. We've got to have, culture relevant providers. People need access to care. They need to be able to get in. We need to have enough psychiatrists. We need residents to be trained in cultural competency and those who train them to be educated. And that in general, there is a lack. We have to be in the spot where
Mhm.
we're not afraid to ask the question as well. That's very important for providers to know. If you don't understand, asking the question does not make you look ignorant. Asking the question makes you look as if you want to know and that you're interested. Asking questions is not a sign of ignorance. Asking questions is a sign of interest in the patient. So we have to make sure that we do that portion of it.
I love that. I think that's so powerful. Can you tell us more about a book that you co-authored called Mind Matters: A Resource Guide to Psychiatry for Black Communities?
Yes, Mind Matters, a resource guide to psychiatry in black communities, is a book that a group of 10 black psychiatrists wrote. We formed our own company called Global Health Psychiatry because we wanted to self-publish the information and we wanted to make sure that it communicated the right message to the community. So this book is written in question and answer format and covers it covers the major psychiatric diagnoses such as depression, bipolar disorder, childhood disorders, aging and dementia, substance abuse, schizophrenia, the major factors. We wanted to make sure that it was short, so far as it's less than 200 pages. Each chapter is less than 8 pages on average. And we wanted to make sure that it wasn't overwhelming to the population. Up until the time we actually put the title on the book and submitted it, we even questioned if should be for black community or to say for black communities because generally it is a psychiatry book. What's most unique though about the book is that it's written in question and answer format based upon the questions that patients, caregivers, and consumers have for the doctor. So it's not written from the paternalistic idea of this is what we want patients to know. It's written from the idea of what do patients, families, and caregivers have questions about. So the entire book is in Q&A format. And another unique thing that we decided to do in this book is that we answered the questions as if we were talking to our grandmother, Big Mama, Mimo, Mama, or whatever we may call her. And when in doing so, as the avatar being your grandmother, it comes off on a sixth, seventh grade type level.
Right.
So it is something that the community can read that talks about the mental health. And what's clear in the book is that it's not as if the information is dumbed down or anything like that. It's actually written in the common language so that people can understand what we're talking about. I've had many people to read this book and say that, oh my goodness, I did not realize that's what my child or what even I have.
Right.
The doctor comes in, they tell me what I had, they explain it to me. But so often, as professionals, when we explain information, we explain it in the language that we learned it,
Right.
which that is not the language of patients. And so patients take the medication hoping to get better, and they don't know what they're supposed to be getting better from
Right.
or what or how it's supposed to work. So by writing it in this format, it has helped a lot of patients be able to understand what's going on in families and caregivers. I've even had policemen, clergy, and even some mental health professionals really enjoy how it's written. But also for the professionals, those who are extremely educated, such as psychiatrists, psychologists, and social workers and whatnot, say they love this book and the wording of it because it gives the language that patients use. And it gives the provider the language to use for the patient to be able to understand in order to explain the information so that the patient be able to understand it. Many people have said the diagnoses sound different in common language, and it sounds so plain and common to people that I've even had persons who are not mental health professionals, who are not very well educated. When I'm saying that, referring to persons, say, with a college degree, say that, oh, that's what it is. That makes sense. And I know other people like me who have these same issues. And now I don't have the fear. We even go through the psychopharmacology in the same direction. We cover dopamine, serotonin, norepinephrine, acetylcholine, and all those issues. And we use common language to explain where it works in the brain, what the medications are supposed to do, and we cover what the medications may cause or what side effects may happen or what should the doctor be monitoring. Another great thing about this book is that we even have a chapter on non-medication management. So essentially, what are the things that patients can do to empower them so that they can take care of their own mental health outside of medication, such as deep breathing, exercise, yoga, diet and nutrition, as we had just talked about, therapies, other things outside of medications that individuals can do to promote their own good mental health and preventive work. And one of the other unique chapters in this book is discussing what to expect from a psychiatric interview, so far as what is the doctor looking for, how the interview should flow, and then also knowing what you should bring to your appointment is going to be very important. By giving patients the knowledge, the understanding of what will happen, it empowers the patient. Just about every doctor will let you know the more that the patient knows of good information, the better the outcome. And I think that this book is key in decreasing the disparities that we see in our community because of the lack of understanding and the issue of fear. Another thing that we cover that makes this book specific to blacks is we do talk about the history of blacks in America, the 400 years, many of those years of slavery, the years of Jim Crow, and realizing that within my generation is the first generation of African Americans to actually have full rights as citizens inside the United States with the Civil Rights Act in the 1960s. So the traumas that we see within the community, the conditions that we're in, really you have to understand there's a system that is in place, that has been in place, that continues to affect how we see America and makes us culturally different. And all of that walks into the room whether the provider wants to discuss it or not. Oddly enough, many African Americans do not feel comfortable discussing that with providers due to the issues of not feeling the provider will understand, or even the shame that comes with many of the things that we've dealt with in the past and that we deal with even currently.
Right. Wow. Well, I think this book sounds incredible, and it seems like it is incredibly valuable to both the providers and the patients. I think it's amazing. So, thank you so much for sharing all of that with us. And there will be a link in the show notes to this book and the next one we'll be talking about. Can you tell us more about your other book, How Amari Learned to Love School Again?
How Amari Learned to Love School Again is our latest book. This book came out and it was introduced for this last American Psychiatric Association meeting that we had in San Francisco. And what this book is about is by the same group, Global Health Psychiatry. What we wanted to do is be able to explain mental health to children. The most common diagnosis that is talked about is ADHD. In the book, we decided to go with an animated characters and go through the symptoms and signs of ADHD so that children can understand their diagnosis and their illness. So often I have a kid to come in and I'll ask, how are you doing? And the child will say, just fine. And then the parent will say, no, this child is not doing fine. And the child will look there confused, like, what do you mean I'm not doing fine? Well, and the parent will go through the symptoms of ADHD. The reason the kid doesn't recognize and understand it is because the kid doesn't even understand what the diagnosis is. in the first place, and many times have no idea why they're in there seeing a psychiatrist or even a therapist, and have clearly no idea why they're taking the medication. Like, no clue what this medication is about. So the point is trying to empower children and their families in understanding ADHD. And the thing about pictures is that, as it is said, a picture says 1,000 words.
Mhm.
And so by seeing it animated as sorts, the child can understand it better because many times children lack the language that adults do. So the reason they don't understand is because if you lack the language, you can't record the information, but they can clearly see the picture. It's written on a first grade level, so it's written for about 6 year olds on that level. Obviously, the pictures are useful. Oddly enough, I have adults who love it who don't even have kids with ADHD simply because they have ADHD and they're like, "Oh yeah, that was me, and that's what was going on." Then we have where the child sees the provider. They make changes at home and at school, so far as sitting in front of the class, making sure that the instructions are directly related to the child, increasing or giving positive affirmation for good behaviors. Also, not doing judgment for poor behaviors, but working with the child, the things the child can do at home as well, so far as chore list and parents talking directly to the child, making sure that the child is listening directly, repeating the information back to the parent, and then you see the growth in the child where they get back to what they were able to do. In this particular story, Amari's superpower is math, but Amari starts to struggle in math and in school. But then, with making the changes in the home and the behavioral changes, you find that he gets his superpower back. And he's not only responding at home and school, but also even we make reference to sports and even to church, so often as you see in the African American community. In the back of the book, we actually have a parent guide. And in the parent guide, we do the same thing that we did with Mind Matters, which is it's all question and answer format based upon the questions that parents have for the provider, such as, will my child be labeled? How long will my child need to be on the medication? Are there treatments outside of medication? What are the available medication options? What are the side effects that the medications may cause or give? What are things that the doctor should monitor? Will my child be labeled? The issue of educational programming, so far as individual education programs like IEPs or 504 type programming, letting the parent know about the services that the school can give to your child. With individual education programs, it is what the school can do for your child. Without that, too often it is punishment of what the school does to your child. So often have African American families who will not want to engage in those services, who do not want the school to know because they feel like their child will be labeled or will have a stigma attached to their kid. And the opposite is true. When the school knows, now the school has to do something to help your child, realizing that the 8 hour day in the school is the majority of the place where your child will be at one particular time while they're awake. So the school being engaged and involved is something that we need not to run from, but something we need to run to when it comes to mental health and ADHD. And that's what we try to do in this book.
Right. Wow, that's also amazing because it sounds like, you focus on the parents and the children. So you've addressed both those issues. I love that. Do you think you could tell us a little bit more about the growing suicide rate among African American youth?
Yes, I would love to. And because this is something that obviously is near and dear to my heart, and you find that suicide rates amongst African Americans are climbing quickly. I know in the U.S. Surgeon General, Dr. David Satcher, showed that between 1980 and 1995, that the suicide rate amongst African Americans between the ages of 10 to 14 increased by 233%.
Wow.
233%. So, in studies since then, we found that this number is continually growing. And we found that in adolescent Black females, that since 2000 to 2017, the suicide rate has grown by 182% and 60% amongst Black males. What's even more startling is the increased rate of suicide in young kids from the ages of 5 to 12, and that Black children are committing suicide at a rate double that of white children in this younger age group, with the majority being Black male children are committing suicide at ages as young as 5 years of age. And this trend is growing. So so when you look at Dr. Satcher's work with the U.S. Surgeon General's office showing that trend early, And up until right now, the rates are steadily increasing. And this is something that greatly needs to be addressed. Now, suicide rates are higher amongst all groups, just about, but it's actually increasing faster amongst African American, both youth, teenagers, and later adolescents. And it's just odd to see this. And the question becomes why?
Yeah.
And really, we don't have really good answers because there's not a lot of data. It's like we've noticed the trend is new, but the questions of why, we really don't know. Things have changed. I would say me growing up as a young black male versus my daughter growing up has been different.
Right.
The things that are said in public and on television, even inside the schools, is stuff that was not said when I was in school.
Right.
Like openly using the N word and addressing your classmates with N word terminology, other racial constructs, things that are said to girls, things that the bullying that is going on, it seems to be getting increasingly worse. And I think a lot of that has to go along with the dialogue that we have in America right now. I would say with the Bush administration, the Obama administration, and even with the Trump administration, when you're seeing public officials address and call each other names, I think it gives an okay for our children to do that. And many of those things need to be checked inside the home. I think parental workloads are very heavy for a lot of families
Right.
right now. You have two families working, two parents working, not enough time at home. So often, I know even in my house, we come home and next thing you know, we have more work to do even once we get home.
Right.
We may have more hours of work to do just to complete what we had done earlier in the day for the last 8, 9, 10 hours, then have another 2, 3, or 4 hours in the evening. I would say also when you look at overall suicide rates, not paying attention to the collective. So often, I'm hearing so many self help books, self help gurus, and too often you don't hear about the collective. You're hearing more about the individual. Put your oxygen mask on first. And it's like, well, you put that on first so you can help everybody else, not put it on first and just watch everything around you fall to pieces. And I think we're just, the social media issue is just gotten completely out of control where people believe that these are people's real lives.
Right.
You look at your life and then you look at, then you
Fake
look at social
version.
media. Yeah, Facebook, and people got their makeup on, Instagram, they got all the angles taken, all the shots taken, not realizing that person is taking probably 100 shots to get
Mhm.
three of them on Instagram. But looking at other people's lives, not knowing that those are not truths, and then comparing your life to what you see around you. Also, this social disconnect that is going on. But even within African Americans' families, the issue of poverty. So often, over half of Black children are raised in single parent
Yeah.
homes run by Black women, realizing that Black women are the least paid Americans on average, I believe, amongst all groups than any other group. So the disparities in pay and living in a home with a single woman and the lack of connected families, I think is also growing the stress on everyone in the home, including the child and the parent.
Yeah. That actually leads me to another question, and I know that there have been a number of sort of movements toward trying to prevent suicide just in general in the country because it is on the rise. And I'm sure you're aware of like the American Foundation for Suicide Prevention, that they're actually putting a lot of research out there and trying to educate the community more about preventing suicide. But now this makes me think that, maybe a whole major component of that prevention needs to be focusing more on cultural competence and how can we address suicide prevention specifically as it is affected within cultures, because I think that definitely comes into play, and that could be a major reason for some of these disparities, because as you mentioned, those statistics are just shocking in the youth.
Yes, I would say very, very shocking in youth. And you have to look at the issue of continual risk. We have to identify the risk, and the studies just have not been done very well. You're starting to see more stuff come out by, I know, Dr. Sean Joe, and I read a few other individuals out there who are doing this work. But we need more stats, we need more data, but more importantly, we need more intervention.
Right.
One of the biggest issues that you have to look at is, access to firearms. That is the most common way that all Americans kill
Right.
themselves. Now, with children, it's more likely to be strangulation or suffocation is the more likely way for a small child to kill themselves. But when you're looking at as you get into the teenage years, firearms are about 90% lethal in killing yourself.
Right.
There, the access, and especially the younger you are, the more impulsive you tend to be, and the inability to work through problems and situations and information. I know another new book out by a colleague of mine, Dr. Ron Bailey, is At Gunpoint: Firearm Violence from a Psychiatrist's Perspective. And you find that having the firearm in the house and loaded and it being readily accessible is the most common risk factor for actually killing yourself. A loaded gun sitting on the kitchen table, is the most likely way that a person is going to kill themselves. Now, when you separate the gun from the bullets and both are locked up in different places,
Hmm.
that causes you to have to mentally go through the steps of whether or not you're going to die. Or even in suffocation. If you're trying to suffocate yourself, you don't die immediately. It'll be well within a minute or two before you start to black out. So, when it comes to cutting off the airway, which gives you the mental thoughts of having to go through it, oh my goodness, I'm dying, I want to live, versus with a gun that is not done. So
Right.
our love of guns, access of children to guns, that has to be something that needs to be looked closely at. You cannot leave, so often people put their gun in a nightstand or something like that. Maybe you don't have kids living inside your home, but then your nephews or your nieces, a friend comes over with a small children. All of that puts a person at risk. So we have to look at that. Perceived racism is an issue. I'll be honest with folk. I grew up in a black community.
Right.
Elementary, middle, high school, college, and medical school was amongst black people for the most part. And then, I look at my own daughter and kids in this area, and they didn't grow up with those with that circle of for lack of better way of saying it, blackness.
Right.
So she grew up in a majority society, mostly white. The things that she's seen are things that I never saw.
Right.
I didn't see that as a kid. I only read about that or saw it on television. But that outward, overt racism, even from peers, and not to mention even students, I mean, peers, students, and
Yeah.
teachers.
Yeah.
It's like it's hard to believe that somebody would pick on small kids, but that's another factor leading to suicide in African American children, is that if you're ADHD and you're a black male in the classroom, one, you're perceived as being more so bad, so therefore rather than receiving help, you're receiving punishment. We're often perceived as being older than what we are and more of a threat in general than the general population. So those societal judgments are transferred into the teacher, so that when they see that kid, they don't say, oh my goodness, this kid is having difficulty sitting still, bit rambunctious in the classroom, they're falling behind in grades. So therefore we need to run in and help them.
Hmm.
No, it's more or less he's acting up, he doesn't know how to act, and then the unconscious bias and the racism sets in and say that we need to punish him
Right.
and save the other kids from him so that we can actually get control in the classroom.
Wow.
Those perceptions are a problem. Also, misidentifying, learning disabilities, intellectual
Hmm.
disabilities is another key factor. Sadly, one of the trends that they've noticed in markers in suicide in youth is elevated IQ with an intellectual disability.
Wow.
Elevated IQ with intellectual disabilities has one of the highest suicide rates. So, one, I'm actually smarter than everyone in the room in the classroom, but I'm not able to perform on some level for some reason.
Mm.
So, be it dyslexia, agraphia, or even possibly a comorbid mental health issue in ADHD, and that I know I can do better, but I'm even more frustrated because I can't display or show
Right.
it. So the mindset of the teacher in the school system has to be, we need to run to these kids, be it black, white, Hispanic, or
Yeah.
whomever, and identify that early and actually engage in services quickly. And that, oddly enough, it is a medical emergency, because the most common risk factor for suicide in a young kid is actually ADHD,
Wow.
not perceptions of depression. Now, there are other reasons that can be why we're saying ADHD first, but that's the diagnosis that's key that has to be addressed quickly. ADHD, learning disabilities, because now if the kid cannot learn, you're setting up a pattern of behavior. But one thing that and I'm just going to throw this in as a sidebar, prisons are built based upon kids' third grade education level, in that your inability to read at the third and when you're in the third grade is a high predictor of whether or not you're going to be incarcerated. And I wonder if these children are noticing that there's a difference here. I can't get it done, so I would prefer to check out of life
Oh, wow.
because I cannot move forward like this. And not having that language and information in that developmental stage where it really could put these kids more at risk.
Yeah, absolutely. So I just have one more question. We're going to kind of shift gears here because I wanted to ask you about your other book that's called Transition to Practice: 21 Things Every Doctor Must Know in Contract Negotiations and the Job Search. Is there a way that you could share maybe a few of those with us today?
Oh man, that's a whole nother book. 21 things every doctor must know. Well, the first thing I tell docs, which is the first chapter in the book, is know thyself. That quote is from Imhotep, which is known as who is known as the first physician and the builder of the initial pyramids. And he wrote that on the outside of every pyramid, which is know thyself. In that you cannot negotiate a contract for you if you do not know what you want and what you're looking for. Too often, docs will build their careers and take their first jobs based upon what is popular in residency, or popular amongst their mentors, or popular amongst their peers, not considering other factors such as where are you at in life? So far as what is your age? What do you want? Are you married? Do you have kids? What kind of lifestyle do you want to have? How much money do you need?
Mhm.
If you go into a job and you haven't considered those factors, many times you could pick the perfect job that is not right for you.
Right.
Realizing that you could be quickly disillusioned and upset with your career or your medical career, not because you don't love medicine, is because you're in the wrong spot for yourself. So that is one of the biggest issues that I see. Many times people, will take a job based upon the money or the power or the respect that the job has. But the fact is that with a career, you have to grow into a career and you have to have the end the end in mind at the beginning. Too often we go to medical school and we're not taught about career advancement, career development, and what is best for you. So often when in residency, you ask people what they want to do, and they say they want to be in academic medicine. Why is that? Well, you've been in academic medicine, you've been a student since the age of 4. Now you're 34, and you want to continue being a student, realizing that the majority of doctors are not working in academic medicine. So, what else is there out there that you may enjoy? And we're not made to explore our minds and our interests and how that impacts us as individuals. We're taught to build our lives around our careers versus our careers around our
Mm.
lives. You need to build your career around your life, not your life around the career, because you have to take you into matter
Mhm.
first.
Yeah, absolutely. I think that's excellent advice. Well, I just want to say thank you so much for being on the show, and you've shared such amazing information with us. So, thank you, Dr. Higgins. It's been a pleasure.
I want to thank you so much for allowing me to be interviewed. I'm happy to be able to give somewhat of my limited knowledge, to the group, and hopefully it will be a conversation starter for persons to gain more knowledge. I'm always open to debate, understanding. Anytime that a person says what they say with a good heart and with honest meaning in it, it's a conversation that's worth having. And I want to give my appreciation to NEI for having the insight to understand how important this is and giving me the opportunity to speak.
Thank you. Thank you so much.
This podcast was brought to you by NEI's Master Psychopharmacology program. This is an NEI member benefit that is designed to help you develop proficiency in the practice of psychopharmacology. Start your program today. For additional information, see the link in the podcast description.